Hello and welcome everyone to the 2026 Influenza Update presented by the ACT Government and Capital Health Network. Please join me in acknowledging the traditional custodians of the land we are meeting on. We pay our respects to their elders past and present, and also to any other Aboriginal and Torres Strait Islander people who may be attending tonight's event. Their land was and has never been ceded. So tonight's webinar focuses on the 2026 influenza season, and there are also some updates on COVID-19 and RSV. I'm Dr. Leonie Harcourt, a GP Education Advisor at Capital Health Network. Also with me tonight is Kanal Mohiti, the Events Lead at Capital Health Network, and of course our expert presenters, Dr. Jeff Wang from NCIRS, the National Centre for Immunisation Research and Surveillance, and from the ACT Health and Community Services Directorate, Alison Kingsbury, the Senior Director of Immunisation, Dr. Nicola Ball, the Public Health Advanced Trainee, and the team from the Immunisation section, who will be working behind the scenes throughout the webinar to answer your questions in real time. So please type your questions as they come to you into the Q&A box and not the chat box. Some of the questions will be answered straight away by the team, and some may be left to the Q&A panel discussion at the end of the night. Or if we don't have time to get to your question tonight, rest assured the team will follow it up with you over the next week. Regarding CPD, please fill in the post-event evaluation survey, which CHN will send to you immediately when the presentation finishes. CHN will also email you a certificate of attendance after the event, and please feel free to self-report 1.5 hours of educational activities to your CPD home. The presentation itself will be uploaded to the Capital Health Network YouTube page, and you are welcome to share it with your networks. Also, just a flag for Health Pathways, which, as many of you know, has free localised information, guidelines and referral pathways on immunisations and infection management. So now to the exciting part of the night and over to the speakers. It's my pleasure to introduce our first speaker for the night, Alison Kingsbury. Alison is the Senior Director of Immunisation at the ACT Health and Community Services Directorate. She heads up the team who develop, implement and manage government-funded vaccine programs and vaccines within the ACT. Alison has worked in critical care nursing, project management and quality and safety. She joined the Population Health Division in 2020 and she has an interest in health system design and improvement. So over to you, Alison. Thank you.
Thank you, Leonie, and thank you to Capital Health Network for hosting today. I'm just going to share my slide. I'm going to give you an update on 3 things tonight. The first is the updates from the government vaccine service delivery and how we do our business. Just as a reminder, the 2025 influenza vaccine program in review and some information on this year's program. So just as a reminder, we changed the model of service, how we deliver, manage vaccines last year. We did this in response to a number of things. One was the increasing volume of vaccines and the complexity of the schedule, but also we had an increase in about 70% of our providers. So we needed to change it up and do things differently. So just as a reminder, all providers must report cold chain events to the immunisation section using the cold chain breach and wastage reporting form. Now we have moved to fortnightly deliveries with no unscheduled deliveries. Providers need to ensure that they're reporting accurate stock on hand. That helps us with deliveries, meeting demand and also orders. And if you do have a cold chain, you'll be required to provide evidence of data logger readings. So in the ACT, we recommend that you keep these for a minimum of 2 years, commencing from when you onboarded with the immunisation section. I will also just remind people that it's really important that you have written processes for downloading that data. We've recently had some experiences where there's only been one person in the premise or practice who's aware of how to do that. They've been off for some reason, and so people aren't able to share with us their recordings. So please be mindful of that. Okay. So How do we go last year? Well, this slide talks about the total administrations from the 1st of March to the 30th of September last year. So you can see that we had over 200,000 administrations, and over a quarter of those were done through commercial enterprises, hospitals, or Aboriginal health services. The other 2/3 were fairly equally split between GPs and pharmacies. So everybody in the primary healthcare world is doing a great job and shares the burden in immunisations around influenza time. How do we do compared to the rest of the country? Well, you can see from this table that we do pretty well, especially in the 6 months to under 5 years. We certainly do nearly double what the national figure is. Our figures for over 65s are fairly consistent. And we've had a slow year-on-year increase in the other groups. Just to note that the groups 15 to under 65 years, this is a combination of NIP and private vaccines. So mostly private because there is a smaller number of NIP eligible people in these cohorts. This is similar data for Aboriginal and Torres Strait Islander people. As you can see, the figures aren't as good, and this is of concern and something we'll be working really hard on this year. We know that Aboriginal and Torres Strait Islander people are more likely to have severe complications from influenza, so we really recommend that you encourage your clients and patients to get vaccinated. Please remember that if someone identifies as Aboriginal and Torres Strait Islander, that is included in your clinical software and recorded on air, because it gives us a better indication of whether these Aboriginal and Torres Strait Islander people are having their vaccinations each year and what we might be able to do to help that get bigger and bigger. In terms of influenza notifications, and this data comes from our weekly respiratory surveillance report, this was to the end of September, you can see that every year is slightly different. The red line right up the top there is last year. And so 2025 was a slightly longer year. We had slightly longer season, and we certainly had the most notifications for a very long time. I guess it's a way of showing that every season is different, and the one thing that people can do is get vaccinated. Similarly, this is self-reporting through the flu tracking app. People reporting from their own homes, illness defined as fever and cough, and you can see that black line is 2026. So, you know, we're off to a steady start already this year. So, 2026, what's in store for us? I'm going to talk a little bit about ATAGI, that's the Australian Technical Advisory Group on Immunisation, and they put out a statement every year about influenza vaccination, including recommendations. So it is fairly similar to previous years. Basically, the recommendation is that everybody over 6 months should have a vaccination for influenza every year. And that's because the vaccine is slightly different every year, depending on the anticipated strains that are circulating. Now, it's also very important for primary healthcare workers and clinicians to remind people and advise them to get vaccinated, because we know from research that a recommendation from a trusted health professional is a single best indicator of their intention to get vaccinated. There is some change this year to the recommendations, and I'll go through those as we move through. I am going to focus on the National Immunisation Program because that's our job. We implement that on behalf of the Commonwealth. Eligibility for the NIP program for flu has not changed. So it remains children aged 6 months to under 5, people over 65, specific populations aged 5 to under 65 at risk of severe influenza, Aboriginal and Torres Strait Islander people 6 months and over, pregnant people, and people aged 6 months and over with certain underlying medical conditions. Now, one of the key changes for this year is the advice around first-time influenza vaccination. Now, I'm not sure if these lovely people have had their vaccines before, but they look pretty happy, so I'm hoping they have. So the advice that's changed is around children. So when receiving influenza vaccine for the first time, it's only healthy children aged 6 months to under 2 and those aged 6 months to under 9 with a medical risk condition that should receive 2 doses 4 weeks apart in childhood. People of any age receiving an influenza vaccine after a hematopoietic stem cell transplant or solid organ transplant or receiving CAR T-cell therapy should also receive 2 doses 4 weeks apart. And that for children is slightly different. So I'll talk a little bit about the focus that we have this year for influenza. And you may have received or seen a letter from Professor Michael Kidd, the Chief Medical Officer for Australia, promoting the free vaccines for eligible groups and also asking us to focus on improving uptake for children under 5, First Nations people, pregnant people, and people over 65. And it's fairly evident that those groups are at risk and may be underrepresented in our coverage. Certainly for pregnant people, we're looking for them to get vaccinated so that they can pass on that protection to their child before they reach 6 months. Now, sometimes these conversations can be a little bit tricky, and so I would refer you to the Sharing Knowledge About Immunisation website or SKY. It's a really valuable source of information, not only for clinicians, but also for families if they have questions about vaccination. And this is just an example of one of the resources around talking to Aboriginal and Torres Strait Islander people about vaccination. Really valuable, so I would recommend you have a look at that. As I said, influenza vaccination in pregnancy, really important. It's recommended in every pregnancy at any stage. Influenza vaccination can be given safely at the same time as pertussis, RSV or COVID. And importantly, people who are pregnant and received a vaccine in 2025 should receive a 2026 vaccine if it's available before they give birth. Similarly, if someone's received a vaccine and before becoming pregnant, they should get revaccinated during pregnancy, again, at any stage. Last year saw the addition to the Australian Immunisation Register of the antenatal indicator, and that allows us to collect data and be able to assess better how many pregnant people are covered by influenza vaccine or other recommended vaccines in pregnancy. And just a reminder that it is mandatory to record a pregnancy status for individuals at the time of their vaccination. Again, at the bottom of this page is the Pregnancy, Birth and Baby logo, and it's a website from the Commonwealth Government. Again, really great information there for people who have questions about vaccination during pregnancy and all other pregnancy-related matters. One of the other groups, of course, that is eligible for NIP vaccines is the medical conditions group. And this is just a list of those conditions. It's available on the Immunisation Handbook website and also with the ATAGI statement. This is one of the resources that the immunisation section provide, and you may have received this with your initial influenza rollout. We'll also provide it digitally with advice on letters about advice for the program, our newsletter, and also the ATAGI advice. So if you haven't received it, please send us an email. We can send you a copy. You'll notice this year that Our vaccines are trivalent, so the Yamagata strain for influenza B has been removed. It hasn't been seen for a long time, and so all vaccines given in Australia this year, whether through the NIP or private, will be trivalent vaccines. This is a really nice slide, which we can provide to you as well. It shows all the vaccines available in Australia. The ones in the white boxes are those included on the NIP. And you may notice there's slightly different names because they are no longer a quadvalent or tetra. So their names may have changed. I'm just going to talk a little bit about how we do our work behind the scenes. We do get a lot of questions about how we come up with allocations, the distribution, and timing for our influenza program. So this slide just outlines how we plan and roll out influenza. You can see step one there. That's completely out of our sort of control. It really is determined by manufacturers, TGA approvals, and the Commonwealth in terms of when we get our stock. Once we do get our stock, it's compiled and we distribute that on the next scheduled delivery for you. So if you haven't received your delivery this fortnight, you will certainly get it in the next fortnight. And our ordering system will open after our initial rollouts have occurred. And so that's after the first two deliveries of influenza, sorry. We've got a little warning sign down here, and we really don't recommend the transfer of stock between providers. Every time you move vaccines, you increase the risk to the cold chain, and we would really prefer that you keep it in one fridge. If you have more than one fridge during the flu season, please make sure that it is compliant with Strive for 5, and please let us know where you're keeping vaccines. Now, the other question we get a lot is there a pattern to vaccinations? How do we know when all of our patients will be coming? It's pretty evident, certainly for the over 65-year-old group. And you may have already seen these lovely people coming down to get their flu vaccination year on year. As you can see, this is our data from last year. That April and May is when they get their vaccines if they're 65 years and older. And I can probably say that after the King's birthday long weekend, the amount of demand there for Fluad really decreases. Similarly, there are the patterns for the other groups receiving NIP vaccines. You can see here that the groups who are eligible between 5 and 64 years have a similar pattern, but not quite as extreme to the over 65. There's not quite that volume. And that blue line is for our 6 months to under 5 group. And that seems to kick off after school holidays around Easter, probably when parents turn their minds to winter and influenza vaccine. So why don't we just open up ordering straight away? Well, we actually don't receive an infinite amount. We don't have an unlimited supply. The Commonwealth provide us with an allocation matching our eligible cohorts. So we want to make sure that every provider starts the season with the optimal amount for them. And each year we know that approximately 20,000 vaccines are distributed but are not administered. So that's a pretty big amount that is wasted, really. So we will strive to give you as much vaccine as we know you've used in the previous years. And once the ordering's open, then we can negotiate with you around how much you might be needing, how much you can store as well safely, etc., etc. So, as I said, we look at initial forecasts based on your previous year. So we take your usage, your amount that you have administered last year, and we try and give you about 50% in your first delivery. Then we try and give you another 25% because we know that approximately 50% of influenza vaccines are administered in the first 4 weeks of influenza being available. In the following 4 weeks, there's about another third to 35% given. So that makes up about 80% in the first sort of 8 weeks of the program. As I mentioned, also remember your fridge capacity. If your fridge is looking over full, we won't deliver it because our realm is to give you viable vaccine. When ordering does open up, the smart form's the way to go. As we said, VaxiGrip for under 5s is our vaccine. Fluad for over 65s, and then there are multiple brands for that 5 to 64 group. If you're having a clinic, please let us know. That will assist us when we get the order and it says you want 200 vaccines. We can work out why. And also, please remember that if you're having a clinic, please ensure that you keep that supply separate to your walk-in or individual appointments. You don't want to run out on your clinic dates. So, and as I said, we don't have unscheduled orders anymore. So really, please be careful with that ordering and that clinic stock. 2 things to end off: live attenuated influenza vaccine or flu mist. Jeff's going to talk to this later. So it's been around for a while and it's a weakened form of the virus. He'll go into that a bit more, I'm sure. Just to let you know that flu mist is not on the NIP in 2026 and the ACT government is not funding a program in 2026. It is available privately and will be around in pharmacies. Noting that it is for that 2 to 17-year-old age group, it cannot be claimed through the NIP process for pharmacists because it's private stock. So please just be aware of that, and please let parents know when they come in that it is at a cost. Pharmacists are able to administer flu mist. And lastly, updates to the pharmacist vaccination standards has occurred to allow them to administer influenza vaccine to children aged 2 and over. Previously, this was 5 and over. It aligns with New South Wales, and if you are giving a NIP-eligible vaccine to a child between 2 and 5, again, it cannot be claimed through the NIP-VIP program because that kicks in at 5 years. So that's a Commonwealth program, a Commonwealth decision. We've been advocating to lower that to accommodate influenza. We're yet to hear how that's going. As always, please stay up to date with your clinical and administration knowledge, and if we can do anything for you, please let us know. And thanks for having me.
That's great. Thank you very much, Alison. And just a flag again. So if you have any questions, type them in the Q&A box, and the immunisation team are trying to answer questions tonight live in real time, which is great. Some questions we'll leave to the end for the panel discussion. And if we don't get to your question tonight, the immunisation team will follow it up within the week. So now, thank you, Alison, and over to our second speaker tonight. Please join me in welcoming Dr. Nicola Ball. Nicola is a Public Health Advanced Trainee at the ACT Health and Community Services Directorate. Nicola has worked across a range of spheres, including communicable disease control and regulatory and research roles. So over to you, Nicola. Thank you very much.
Thank you, Leonie. Good evening, everyone. So I hope my screen is visible. I'll be speaking to you about vaccinations for respiratory syncytial virus, commonly called RSV, COVID-19, and our winter wellness messages. So as you know, RSV infects most children by 2 years of age and is a leading cause of hospitalisation due to lower respiratory tract disease in infants aged less than 12 months. RSV is also an important cause of respiratory disease and hospitalisation in older adults. We're very fortunate to live in an exciting time for RSV prevention. Several prevention products have come onto the market in the last few years. They are the RSV vaccines, Abrysvo and Arexvy, and the monoclonal antibody nirsevimab, which has the trade name Beyfortus. From the infant side, so the first two circles on the slide, the ACT RSV prevention program aims to protect newborns and at-risk infants through maternal vaccination and/or passive immunisation with Beyfortus for eligible infants. For older adults, both Abrysvo and Arexvy are registered for use in adults aged 60 years and over. Arexvy is also registered for use in adults 50 to 59 years of age who are at increased risk of RSV disease, which I'll speak to in more detail on the following slides. The vaccines for this older adult cohort are not currently funded under the National Immunisation Programme. So starting with the antenatal RSV vaccine, Abrysvo is the only RSV vaccine registered for administration in pregnancy, and this is funded under the National Immunisation Programme. We've had really excellent uptake in the ACT at more than 82% in the first year of the vaccine being available for antenatal patients. Antenatal Abrysvo is recommended year-round and can be co-administered with other vaccines used in pregnancy. A single dose is recommended from 28 weeks gestation. A new update to the Australian Immunisation Handbook in February this year reflects the updated recommendation that Abrysvo be given in each pregnancy from 28 weeks. So that's to provide maximal protection for each infant. Also a reminder to record pregnancy status at the time of vaccine administration in the air via the antenatal indicator. So Beyfortus is registered for use from birth, and states and territories fund Beyfortus for eligible infants up to 24 months. In the ACT and in New South Wales, the Beyfortus program is year-round. The majority of doses are given to eligible newborns at hospital when they're born. However, if this dose is missed or a second season dose is required, these can be ordered in primary care. We have updated our 2 decision aids to guide clinicians through eligibility for Beyfortus. These aids and the eligibility fact sheet can be found on the ACT government website under Health, Vaccines and Immunisations. As you can see here, for infants under 6 months who have adequate protection from maternal vaccination with Abrysvo and do not have risk conditions predisposing them to severe RSV disease, do not require Beyfortus at birth. However, if they don't have maternal Abrysvo coverage that was given more than 2 weeks before delivery, or they have a risk condition, or the mother has severe immunosuppression or has been on cardiopulmonary bypass or ECMO, then Beyfortus would be recommended at birth. Eligible newborns should be identified and offered Beyfortus prior to discharge from hospital. If that does not happen, they're eligible up to 6 months of age and can access a dose in primary care. This flowchart is for infants and young children aged 6 months up to 24 months. Children in this cohort who are Aboriginal and/or Torres Strait Islander or have a risk condition placing them at higher risk of severe RSV disease entering their second RSV season should be offered Beyfortus. As I mentioned, these resources and an accompanying fact sheet on eligibility that outlines the medical risk conditions is available on our website. A note to dosing, so Beyfortus comes in 50 and 100 milligram formulations. For infants born during or entering their first RSV season, the dose is 50 milligrams if they weigh less than 5 kilos and 100 milligrams if they weigh 5 kilos or more. For older children entering their second or subsequent RSV season, the dose is 200 milligrams, so that's 2 100 milligram doses, preferably injected into different limbs during the same visit. A single dose of RSV vaccine is recommended for all adults aged 75 years and over. We know that RSV hospitalisation rates increase with age, and people aged 75 years and over are likely to have the greatest benefit from vaccination. This cohort can either receive Abrysvo or Arexvy. There's no brand preference in this age group. Aboriginal and Torres Strait Islander adults and non-Indigenous adults with medical conditions that increase their risk of severe RSV disease, aged 60 years and over, are also recommended to receive an RSV vaccine. Other adults in the 60 to 74 year age bracket can consider vaccination. Adults aged 50 to 59 years who have a risk factor for severe RSV disease can consider a single dose of Arexvy, and Arexvy is the only vaccine registered for this cohort. The list of conditions associated with increased risk of severe RSV disease in adults is available in the Australian Immunisation Handbook. In older adult cohorts, RSV vaccine may be given at any time of year, but where possible should be offered before the start of the RSV season. Protection lasts for at least 2 years, and the need for further doses hasn't been established. Given the heightened risk of respiratory disease during winter, please consider co-administration of influenza and COVID-19 vaccines where appropriate. Regular COVID-19 vaccinations are the best way to maintain protection against severe illness, hospitalisation, and death from COVID-19. They are especially important for anyone aged 65 years or over and people at higher risk of severe COVID-19. So this slide outlines the current recommendations for primary courses and booster doses. You can stay up to date with any changes to these recommendations by referring to the Immunisation Handbook and the Department of Health, Disability and Ageing website. COVID-19 vaccines are funded for all eligible individuals, including people without Medicare. I'd like to take this opportunity to promote opportunistic offers of other vaccines, like those for pneumococcal and shingles, when eligible individuals attend for their annual influenza vaccine. So on this slide, I've outlined the eligible groups under the National Immunisation Programme, but please do refer to the handbook, the Immunisation Handbook, as for some conditions, the handbook recommendations are broader than the eligibility under the National Immunisation Programme. So for pneumococcal, the childhood schedule is Prevnar 20, which is a 20-valent pneumococcal conjugate vaccine at 2, 4 and 12 months, with a 4th dose at 6 months for Aboriginal and Torres Strait Islander children. Non-Indigenous adults aged 70 years and over are recommended to receive a single dose of a pneumococcal conjugate vaccine. First Nations adults aged 50 years and over are recommended to receive multiple doses, so please refer to the immunisation schedule for those details. Infants, children and adults with specified medical risk conditions are also recommended to have additional pneumococcal vaccines. Please refer to the ACT immunisation schedule and the Australian Immunisation Handbook for details on the formulations and the dose intervals. For shingles, the handbook recommendation is that immunocompetent people aged 50 and over receive a 2-dose schedule of Shingrix 2 to 6 months apart for the prevention of herpes zoster and associated complications. The eligibility under the NIP is 65 years and over for non-Indigenous adults and 50 and over for Aboriginal and Torres Strait Islander adults. Eligible people aged 18 years and over with increased risk due to underlying conditions and or immunomodulatory or immunosuppressive treatments are also recommended to have a course of Shingrix, in this case 1 to 2 months apart. For all vaccines, there are steps that can be taken to mitigate the risk of vaccine administration errors. Checking the Australian Immunisation Register before administration allows you to confirm that the individual has not already received this vaccine. Reporting to the EAR is mandatory and ensures a complete, accurate and up-to-date record of immunisation coverage across Australia. As Abrysvo is the only RSV vaccination registered for use in pregnancy, it may help to store Abrysvo separately from Arexvy if you stock both in your practice. And thank you for continuing to report vaccine administration errors to us using our online form. This is any instance when a vaccine is incorrectly stored, prepared, or administered outside current clinical guidelines. Adverse events following immunisation, or APHIs, are notifiable in the ACT. We encourage you to report whenever you're suspicious that a vaccine contributed to a reaction. You don't need to be certain of a causal association to make a report. The TGA has released a CPD learning module on APHIs that's worth a look. It covers the why, what, and how of reporting APHIs and what the TGA does with reports. We pass on all APHI reports that we receive to the TGA, so reporting to us contributes to national APHI surveillance as well. I'd like to end on sharing our key winter wellness messages for residential aged care facilities. As we go into winter, please ensure residents and staff are up to date with their vaccinations. COVID-19 and influenza vaccines can be safely co-administered. Please make sure all residents have a plan for testing and a discussion around antiviral medication before they do become unwell. It's also a good opportunity to review facility outbreak management and infection prevention and control plans. And thank you for your excellent work in reporting gastroenteritis and acute respiratory illness outbreaks to ACT Health on our Outbreak Hub. Please feel free to continue posting questions in the chat, and our moderators will respond or will address them at the end. And that is the email address for the immunisation section if you have any questions. Thank you. I'll pass back to Leonie.
Thank you very much, Nicola. And yes, if you've typed your questions into the chat box, could you copy and paste them into the Q&A box so they can be answered? That would be great. Thank you very much. And now on to our final presenter for the night. Please welcome Dr. Jeff Wang. Jeff is a research fellow at the National Centre for Immunisation Research and Surveillance, NCIRS, and an adjunct lecturer at the University of Sydney School of Pharmacy. He is a practicing community pharmacist and has qualifications and experience in vaccinology, clinical pharmacy, systematic reviews, and guideline development. In his role at NCIRS, Jeff undertakes research and systematic reviews that inform clinical guidelines related to immunisation. Jeff leads the implementation of grade methods, which I'm sure he'll let us know what that means, in the development of recommendations in the Australian Immunisation Handbook, and he is about to become a father for the second time, maybe in the next 24 to 48 hours. So thank you very much, Jeff, for taking the time to present to us tonight.
Thank you, Leonie, and thank you to the team for having me. Hope everyone can see my screen.
Yep, we can see your screen.
Yep. I'd like to just share with everyone today a little bit about the live attenuated influenza vaccine, LAIV, or flu mist. It goes by many names, the intranasal influenza vaccine. And these slides have been prepared by myself as well as the NCIRS flu team, as well as Dr. Ashna of the team. I'd like to just acknowledge their contributions. And before I begin, I also like to acknowledge the traditional custodians of the various lands that we're joining this meeting from. For me, it's the Gadigal people of the Eora Nation here in Sydney. And I'd like to pay my respects to elders past, present, and emerging, as well as to extend that respect to any Aboriginal and Torres Strait Islander people with us today. Today, I'll just go over a little bit about the background of LAIV. It's been used internationally for decades before coming to Australia. I'll go through some of the information about its safety and effectiveness, as well as the administration techniques, since it's a new route of administration, and a little bit about its introduction here this year. I've been asked to write a few learning objectives. Hopefully after today, you'll be able to define what LAIV is and how it differs from injections, some common side effects, as well as the effectiveness of it, and the administration technique. So just on the background, the LAIV will be available in Australia for the first time, and it's registered on the TGA for ages 2 to under 18 years of age, so for children only. And it is a slightly higher age group than the injections. As you know, that one is available from 6 months and above. And as Alison has already mentioned, that this is not yet on the NIP. And it's available in some state programs. As I understand, ACT is not one of the states or territories that's having a program this year. But even the state programs that some of the states are running are relatively small, more like covering the 2 to 5 age group, to keep it small. And really, it has been used extensively overseas, more in North America since 2003, and most famously in the UK since 2013. And I'll go into a little bit about the SU programs. And it's delivered in 2 sprays, so 1 spray into each nostril. And as Alison has already mentioned, that this year all of the flu vaccines will be trivalent, same as this one. And this is a little diagram about how these ones work, quite a bit different to the injections. What's containing here are live attenuated viruses. So they're weakened form of the virus instead of the inactivated in the injections, which are killed. These are also cold adapted, so they replicate only in the nasal passage and the airways, so not in the lungs. Once it goes into the lungs, the environment is actually too hot there for it. So this really reduces the risk of it causing an infection. And it also stimulates the immune system quite differently to the injections, as it mimics more a natural infection, as where the nose and the mouth is probably where you usually would get influenza virus anyways, and it stimulates mucosal immunity and more the IgA antibodies and cellular immunity. And it's people argue what this means, but the data has shown us it probably is better against transmission than the injections. So this is the comparison between the LAIV and the injections. The injections being on the right. With the injections, we tend to see a huge hemagglutinin immune response. That's antibody sort of immune response, which is how we usually measure the amount of antibodies that a person's blood will have after the injection. Whereas with the nasal spray, as I said, it's more nasal hemagglutinin A and cellular responses. So what we have seen in some studies is that it probably has a broader protection, even if the circulating strain is not as well matched to the included strains in the LAIV. It might have a better protection than the injections, and a huge indirect benefit to as we've seen in the UK, which I'll go into a little bit. So the UK program actually started in the 2013-2014 season. As you know, in the Northern Hemisphere, this winter goes over the year, so that's how they call their seasons. And it started in a rolling fashion with expanding age groups every year. So when they started off, they only included 1 year group, so people aged 2 to 3 years old. And these will mostly be preschool kids and mostly be done in GP clinics. And every year they sort of extend the program to more people, more age groups. And by 2019, it has rolled out to all the age groups in primary schools. And they were going to take a break, but of course, 2020, the COVID pandemic happened. Everyone was a little bit desperate to get as much protection into the kids as possible. So they slowly rolled it out to high school as well over the pandemic years. By the 2023-2024 season, it actually is rolled out in as much as they could in secondary schools as well to people up to 16 years of age. The UK people came and presented at Targi with us. They try to explain why it doesn't go up to 18. Their school system is a little bit different there. They try to explain to us, but we didn't fully understand. But that's sort of the maximum they could do. And yeah, it had a very dramatic impact on coverage because if you do them in school programs, as we know in some of our school programs here, the coverage gets really, really high. And in places where high coverage is observed, indirect benefits are observed for all the population, not just the kids that were vaccinated, but the whole population in the areas where they had high coverage of LAIV. So this is quite dramatic geographically. So this compares different areas of the UK. Scotland and Northern Ireland is areas where they had very, very high coverage, so something like 70%. Just to give an idea, our flu coverage in children under 5 is like 25%. So 70% is a hugely high. And they compared it to places where the coverage is, they did have the program, but the coverage is not as high, and compared it to the Republic of Ireland, which didn't have a program at all. So you can see that after the introduction, which is the dotted line in the 2013-2014 year, the season is meant to look like this. Every year, it peaks around winter, And this is GP presentations for the whole population, right? And the season almost has been eliminated in Scotland and Northern Ireland because of the introduction of the programs. And again, this is just not just kids, and this is all of the population. So it just shows the potential for a dramatic indirect effect. Of course, we're not really talking about a school program in Australia yet, but potential is there for the future. This is a bit more about safety and effectiveness. So being a different form, a different route of administration, we will expect a slightly different adverse event safety profile to these vaccines compared to the injections. Obviously, there won't be any injections like pain or redness. Most likely will be nasal symptoms like runny nose, and it does occur quite often. So we'll be expecting those. And as to the other side effects are very similar to the injections and not any more severe than the injections. A few contraindications because it is live. It is not to be given to children with severe or moderate immunocompromise. These levels of immunocompromise actually has been defined in the Australian Immunisation Handbook. Please refer to it for details of certain medical conditions or people's on different medical therapies that may make them moderate or severely immunocompromised. And of course, we'll prefer the injections for those kids. And it is only registered for people 2 years and above, so not to be used in children younger than that, because the trials and all that has always been done in those age groups. And to be honest, under the age of 2, it is a bit hard to squeeze anything into those babies' noses. And it is contraindicated in children taking solicited late therapy, as well as the normal anaphylaxis to any ingredients, including excipients to the vaccine. Wheezing and exacerbation of asthma is one of the issues that in the initial stages, like 20 years ago when they first started using it, people thought that it might be an issue because of the spray in the nose. But since then, there has been many studies in this area, and a recent systematic review, including studies that had included more than 15,000 participants, have shown that the rate of wheezing and asthma is actually not different from people getting the injections. So these ones are comparing the odds ratios. Odds ratio of 1 basically means it's the same as comparing the LAIV to the injections. So you can see all these, they're basically around 1, and the confidence intervals always cross 1. So we're very sure that it won't cause more asthma than the injections. With influenza vaccine effectiveness, another area that people generally talk a lot about, influenza vaccines, unfortunately, is not as effective as some of the things that we're used to, like the childhood vaccines. But it is expected to be around 40 to 60% effective against GP presentations as well as hospitalizations. It depends year to year, depending on how well the strains in the vaccine is matching with the circulating strains. Depending on the population group, it tends to be more effective than in children than in adults and older adults. And of course, what outcomes we're talking about. So even if you get the flu after getting the vaccine, you're likely to have a more mild version of the infection, and it reduces the disease severity and absenteeism related to that. And of course, we're sure that increasing coverage will not only protect the healthy population, but especially be important for the at-risk groups. So just to talk about in 2025, talking about the injections only, these are obviously last year we haven't had the nasal spray yet. These numbers are actually quite good, exactly about what we expect for flu vaccines, as I mentioned before, 40 to 60. And if you look at the confidence intervals, it's exactly where we expect it to be. Of course, with the longer season, as Alison has mentioned, especially the interseasonal activity, we saw sort of get going into summer, highly unusual because of the subclade K. The H3 effectiveness was not as good, which is as expected because the circulating strain was quite different from what was in the injections last year. But even with that anomaly, the total numbers are quite good, and it was actually better in children than in adults. And yeah, so even in a relatively bad year, it wasn't that bad. And just about the effectiveness of the LAIV. So this is quite a few different systematic reviews comparing LAIV to placebo. It's about the same as the injections, so about 40 to 80 depending on the year. And this is a systematic review comparing LAIV directly to the injections. Goes here and there, but mostly about the same. So as I mentioned before, if the confidence interval crosses 1, basically means it's about the same. This is just a summary table of what I have described, the differences between the injections to the LAIV. Both trivalent, and the LAIV obviously is a weakened live virus, and it is 2 sprays in the nose instead of an injection. Very similar effectiveness. Different safety profile with more nasal and throat symptoms. Only registered in kids 2 to less than 18 years of age, whereas the injections are for everyone above the age of 6 months. And not yet on the NIP, but we'll have some state programs. And you can refer to the NCIRS website for the specific state programs if you have patients moving across the border. And just a little bit about the administration technique, because it is a new thing. It's relatively easy, but it's still a strange thing when the first time you see these things. It looks like a needle, but it's actually a spray. On the top, there's nothing there, so you can't actually attach a needle to it. One of the things with these ones is that it actually has a shorter expiry date than the injections. So we do recommend the first step with anything. We should check the expiry date, but especially with these, because it only probably has like a 4-month expiry date. Will be expected to be if we get it around March or April now, it might be gone by August. So by August, your injections in the fridge might still be okay, but these ones definitely double check. They might be expired. So with these ones, it comes with a dose divider as well. So with the first squeeze, you can it stops you, and then you take away the dose divider and squeeze into the other nostril. I realize it's a little boring for me to talk about this and look at pictures, so I actually have a video here. Hopefully the video works.
This video shows how to administer influenza virus vaccine nasal spray in children and adolescents. As you lay out the applicator, check for any damage. For example, if the plunger is loose or displaced from the sprayer, or for signs of leakage. Check the expiration date. Do not use the vaccine if the date shown on the applicator label has passed. Remove the rubber tip protector, but make sure that you do not remove the dose divider clip at the other end. Now you are ready to administer the vaccine. Make sure the child is in an upright position. For a small child, this may be seated on a parent's lap. There is no need for the child to actively inhale or sniff during administration. Place the tip just inside the first nostril to ensure the vaccine is delivered into the nose. With one motion, depress the plunger as rapidly as possible until the dose divider clip prevents you from going further. To prepare for the other nostril, pinch and remove the dose divider clip from the plunger. Place the tip just inside the other nostril and, with a single motion, depress the plunger as rapidly as possible to deliver the remaining vaccine. And that's it. You're done.
Yeah, hopefully you could hear that.
Yep, we could hear that.
Yeah, all good. Yeah.
Don't forget to
And
record.
there are many videos available like this. It's been around for a long time. You can find the American video, the British video. But yeah, it's good to review these the first time you use them. Just a little bit about its introduction in Australia. As Alison has already mentioned, the NIP program actually hasn't changed at all this year, and I don't think your ACT schedule has changed that much as well. Still, these age groups are listed here. Of course, some of these overlaps with the registered age of LAIV. You can speak to the patient if they're above age of 5, and they could pay for either the injection or the LAIV. Just a little bit about the state-funded programs. As I mentioned before, generally 2 to 5 years of age. In New South Wales and South Australia, it's people under 5. In Queensland, they include the 5-year-olds as well. And in Western Australia, it's 2 to 12 under 12 years of age. So as always with these state programs, there's differences. If you have some visitors from interstate, you can always look these up. And of course, people can purchase these on the private market. They are a little bit more expensive than the injections, but of course, this is a discussion between the provider and the patient. See if they have specific needle phobias or if they're willing to pay for not an injection. And yeah, as I mentioned before, this is just a summary of it being available for the first time in Australia. There's been a lot of questions about why it took so long to come to Australia. It really has been a sponsor's decision. They have actually never made a Southern Hemisphere version of this vaccine. I don't know if it's their manufacturing capacity thing or just never had a idea to do this. Um, uh, as you know, like our seasons are a little bit different from the Northern Hemisphere, and it's just the first time that they're doing this. And a lot of people also ask why is it not in adults? There are certain settings in the world where it is registered in adults. Um, I, of course, can't comment on why TGA didn't do that. This is completely a decision up to the TGA, and of course, dependent on sponsors' application to the TGA. But we did review some of these data. Because of its wide use in children, we have a lot of data both in randomized controlled trials as well as observational studies about its effectiveness and safety in children. We have less in adults. So the data is just not as good. And from the not as good data, the effectiveness is also not as good. Um, so And of course, we've always mentioned that healthcare provider recommendation is such a huge part of a patient's decision to vaccinate themselves or their child. Research has shown that the healthcare provider recommendation it really changes the direction a patient will go. So we always recommend that active recommendation from all of you is very, very important. And I just want to end on a few FAQs because this is a new vaccine coming to Australia for the first time. We've been getting a huge number of FAQs regarding this vaccine, both from the states that are having a program as well as from the public and from the providers. And there is an NCIRS list of FAQs that's available. You can look it up on NCIRS website, and I'll have a QR code at the end for those as well. Happy for you to have a look. And a few of the things that are being asked multiple times is that because it's live, people are a little bit worried about the co-administration issue. As you know, with the live injections like MMR, we generally recommend them to be administered 4 weeks apart from other live vaccines. This is not the case with the nasal spray. They can be administered just like the injection flu vaccines with any other vaccine at the same time or at any interval before or after. It has been co-administered with other live vaccines. We have data on this. Listed there, MMR, MMRV, polio, and it had a similar immune response as well as safety profiles compared to when they were administered apart. And close contact with people who are severely immunocompromised as well. So, for example, if you had an adult in the household who's severely immunocompromised, the kid is healthy. Should we vaccinate this kid? So there is a theoretical risk with the shedding of the virus because it is live. This is a highly theoretical discussion in immunology. Of all these years of international experience of use of this vaccine, there hasn't been any cases of this reported. Of course, it is a theoretical risk. There can be some shedding of the virus, but again, it is a weakened form of the virus. If the person is really, really worried, we could always vaccinate the kid with the injections. Yeah, so and a few more FAQs just on flu in general. There's the co-administration one. Any flu, as I said. Egg allergy. Again, this one is made in eggs, but similar to all the other egg injections, we recommend that it is safe to administer because the amount of egg protein in there is so little. Latex allergy, not a thing. All of the flu vaccines available this year are latex free. Close contact, as I already mentioned. And even after influenza infection, the influenza vaccine is still recommended, of course, because it contains multiple strains. So even if you had a flu A infection, the vaccine can still protect you against the other flu B as well as the H3. So. Yeah, and this is the QR code to the NCIRS resources. We've had a big update, a huge suite of resources available, both about LAIV and comparison tables. Yeah, happy for you to have a look and happy to answer any questions today as well. That's all from me.